introduction. Um, just only quick one change that once she described that the gaps in knowledge, I shall deliver that on the 11th, which is Wednesday at 4 o'clock. The first talk is the glycemic control with intensive insulin therapy. Maybe you can dim the light so slide can be seen better. Is fundamental to renal preservation in diabetes. I want to tell you something that you ought to know, that I'm a nephrologist by education. By education, but why did I take up diabetes as my focus? Because of the fact that I used to go to as part of my round in the dialysis clinic, and I see too many diabetes patients on dialysis. And I asked that question, that why so many diabetes patients are on dialysis? I did not find any reason. So I went to the laboratory, and that's what I always do. I always go to the laboratory to find the answer. So we started doing cell culture study to study the response of the vascular endothelial cell to high glucose level. And we went through many, many phases of this study. So that led me to the area focus on and step into the diabetes area being a nephrologist. So I'm in a better advantageous position to talk about diabetes than a diabetologist or an endocrinologist from the perspective of nephrology care or dialysis, which is the big part of nephrology care. So I commonly ask, as you can see, the commonly asked question as soon as the diabetic patient come to my office, doctor, do I have to go to dialysis? And this is a very common apprehension among the patient with diabetes, that they have to go to dialysis or they undergo amputation. So my answer is, as you can see, why this question emerged? Because too many patients with diabetes are developing end-stage renal disease or ESRD and entering into dialysis. So my answer to this question, no. So you find out how I give this answer to my patient, no. Problem in diabetes care. You always hear about type 1, type 2 diabetes. Patients come to me and tell, oh, I have type 1 diabetes. Some come to my office and say, I have type 2 diabetes. Now, they use that word as a bird. They were told by somebody, you have type 1 or type 2. They do not know what is type 1 or type 2. So it's a big discrepancy between the patient knowledge and the doctors, what they provide. They do not know what is. So what's the purpose of this? Now, World Health Organization described this, of course, type 1, type 2. They even do not know what they're talking of. They're type 1, insulin dependent, but that's not true. Adults are all insulin dependent. You will be surprised to see how many adults, they all need insulin. Type 2 is a non-insulin dependent. Now, WHO classification perhaps is good for physiologists to investigate why you are talking type 1 or type 2, but not good for clinicians. We are involved direct patient care. There is no established criteria to distinguish between type 1 and type 2. Prevailing paradigm of therapy to treat an adult with diabetes by mono, dual, or triple oral agent is wrong. That's why they call you, any of you adult, come to my office and with a glucose of 150, I tell you, oh, you have type 2, and it's automatically written on the wall. I don't have to see the patient. My nurse practitioner will write metformin, lisinopril, glyburide. It's a formula. It's as a hook, all this. result is more common and worse complication in adult than in children. And that's why they describe that, well, no, adult has a vascular lesion already, and then the children, that's why they develop dialysis, they develop amputation. No, those are wrong. All these are always wrong information to support pharmaceutical industry to sell their product. And you will see one of my slides later on. Okay, here is a look at 21-year African-American female, 86 pounds. She lost weight a lot. She had diabetes since age 15. She is currently treated with a glargine insulin by me, BID, and regular insulin by sliding scale, and she has done very well than she did before, many years before. But even then, look at her fasting glucose, 236, but 2 hours postprandial under good control because she took the glargine insulin and the regular insulin, which is the crux of 2 hours postprandial, is the crux of diabetes care, but was never told to her, so she tried to come to me from another diabetologist. Okay, on your right-hand side, 70-year white male admitted to the hospital, excessive urination, feeling weak, tired, and look at her glucose at the emergency room, 639 milligram per deciliter. She was treated with the intravenous insulin initially, then by subcutaneously, and as you can see, to 24 months later, her glucose, fasting glucose, onto your right is 112, 2 hour postprandial, 180. Hemoglobin A1C, 5.6%. Once you see 5.6% hemoglobin A1C, a diabetologist says, well, why do you need insulin? You go to the oral agent because they all go by hemoglobin A1C. Look at her, look at his hemoglobin, look at his 2 hour postprandial, 180. Now, the point I want to make in this, I wish there was a pointer here, no pointer. The serum insulin response. Look at that young lady. Serum insulin fasting is 55.1, 2 hour postprandial, which is a challenge, went up to 86. Whereas the gentleman, 70-year-old gentleman, look at his insulin response, much, much lower than the young. That's what most diabetologists will tell. Well, type 1, you have no insulin response. Type 2, you have a big insulin response. These are all wrong information given to the patient to help pharmaceutical company sell their product. Okay, so the question is, who has type 1 diabetes? Does patient A or patient B? Who has type 2 diabetes? Patient A or patient B? So my question is, okay, patient A has a higher insulin response than patient B. Then does patient A have type 2 diabetes and patient B, which is a adult male, 70-year male, has type 1 diabetes? What's the purpose of saying all this? Unnecessarily complicating the life. Make life easier. Why don't you say, my question is it relevant to stratify type 1 or type 2? What purpose does it serve to stratify? Say it. Is it not accurate to inform each patient that you have diabetes and your treatment is insulin? Not oral agent is not going to help you at all. A splendid article. These are all buried by the pharmaceutical company. They say, oh, too old. There is no such thing in practice of medicine. Old is a traditional. Practice of medicine, traditional. Today's talk is traditional medicine. That means tradition plays an important role. Practice of medicine is not automobile industry. New car, new husband, new wife does not work in practice of medicine. It's all traditional. you had to follow. So here is a wonderful article from NIH by, you can see 1979. 2-hour postprandial glucose greater than 200, or 1 hour, you can say also use 1 hour, but 2 hour is the best. 1 hour glucose greater than 200 milligram per, or 11.1 millimole per liter. That's the National Diabetes Data Group published that in 1979. 2-hour post-challenge glucose equal or greater than 200 or 11.1 millimole per liter is the key for diagnosis of diabetes. So in order to help patients, I don't use too many numbers like American Diabetic Association. Less than 200, more than 200. Anything glucose over 200 milligram or 11.1 millimole is diagnostic of diabetes. Now, I don't want to dwell too much on this table. All I want to show you the 2-hour postprandial. Take a look at how sensitive, 97% sensitivity. What that means? That you have a 3% chance that you may miss a diagnosis of diabetes. Whereas, look at the fasting glucose. Sensitivity is such a lower, no matter what number of fasting glucose you take. What happened? All you give metformin, a patient come in with 150 milligram glucose and you put on metformin, glyburide and so on and on. There are all these oral agents. They eventually develop overt diabetes and develop complication. Take a look at this patient. 66 years African American female came to me October 2010 with the itching in the private area. And she was told she had type 2 diabetes. Typically, I hear every day in my office. She was prescribed glimepiride, which is like a glyburide, metformin, metoprolol for blood pressure control, and lisinopril, most dangerous drug that almost invariably will lead to renal failure sooner or later. I have plenty of data on that. Blood pressure sitting slightly elevated. I discontinued lisinopril, put her on amlodipine for control of blood pressure, other medicine I continued. Second visit, November 2010, abdominal gas, blood pressure still about same because I gave a very low dose amlodipine. Glucose, not bad at this time because she is still getting the oral agent. And look at the kidney function, already decreased. Hemoglobin A1C did not change much. I increased her amlodipine to control blood pressure, and I continued oral agent. I'm not against anything. I'm a very systematic logistic. I follow through, then at some point come that I have to take act on. I put my foot on anybody to help my patient. Now the blood pressure better control, kidney function improved because I discontinued lisinopril. You can see eGFR increased. I continued the same medicine. At this point, her 2-hour postprandial as highlighted, 2-hour postprandial already elevated. Now, take a look at the next visit. See, she is overt diabetes. Look at fasting glucose 372 and 2-hour postprandial 390. So is it not that the previous doctor were doing something wrong to this patient? If she did not come to me, she would have ended up in dialysis already, because all they will be hearing, now you're get ready to go to dialysis. So at this point, I discontinued metformin, glimepiride, and put her on glargine insulin. Her follow-up are all wonderful, but I show you the most recent follow-up. November 2013, her blood pressure perfectly normal, MAP 87, normal MAP 95 or below 95, perfectly normal blood pressure, glucose control great, and her kidney function is stage 2 chronic kidney disease. She is getting Lantus insulin, she is getting Humulin R before meal and metoprolol, but she is sometimes diet non-compliant. She cannot control her diet, so I put her on acarbose 5-glucosidase inhibitor to inhibit absorption of glucose. She developed gas as a result of that, does not like that very much, and potassium. So what did you tell this patient? You have type 1 diabetes, you have type 2 diabetes, or you have diabetes which is well controlled with the insulin. Glucose control with insulin improved her kidney function from CKD stage 3 to CKD stage 2. That's the outcome measure. Diabetology, I go to the diabetes meeting. All they talk about hemoglobin A1C. But what's your objective? What are you looking at? Are you looking at kidney function? Are you looking at cardiovascular function? Are you looking at foot ulcer? Are you looking at gangrene? Nothing, no outcome. You have to focus on an outcome measure. I'm a big nephrologist, so my outcome focus is kidney function. So what is the reality? Diabetes. And why documentation of diabetes fundamentally important? Postprandial hyperglycemia. You have to document diabetes. Robust association between 2-hour postprandial hyperglycemia and cardiovascular risk. Epidemiologic studies showed the continuous graded relationship between cardiovascular death and 2-hour postprandial glucose challenge. Now take a look at this. This is a largest European study called DECODE study, over 29,000 patients. Even though the glucose level, those are post-challenge, are within normal range from 94 to 190. They are within normal. Less than 200 can be considered normal, but still their cardiovascular death 2 to 3 times. So post-challenge glucose, you have to obtain that. You have to send the patient, please go to the lab fasting and then eat breakfast or lunch. Like in India, big meal is a lunch, equivalent to 70 gram carbohydrate. Take your insulin, go to lab 2 hours later. And that's what tells me that how good the diabetes control is. Not the fasting glucose, not the hemoglobin A1C. Here is our own study that shows you, prove you that what do I do. 2-hour postprandial can be used as an important marker to predict renal function change. But because of the controversy, fasting versus 2-hour postprandial, we innovated called D-glucose, 2-hour postprandial minus fasting as shown there. D-glucose obviates the dilemma between fasting, validity of fasting glucose and 2-hour postprandial glucose. And we find excellent correlation with the renal function parameter as shown here. You can see the dashed line are greater than 200, dotted line are less than 200, and continuous line are the all patient. The all 56 patient shows those with a greater than 200, their serum creatinine. Oh, thank you. I don't know whether it's showing well. Oh, this one. Okay, now I see. See that continuous line, a dashed line? Okay, so, and here is the D-glucose. Here is the serum creatinine, and here is the D-glucose, here is the eGFR. Just you can see as 2-hour postprandial greater than 100 milligram D-glucose, there is a significant increase of serum creatinine, similarly significant decrease of eGFR. And we published this data in 2011. So what do we find? The 2-hour postprandial greater than 200, for every 100 milligram increase in D-glucose, serum creatinine increased by 0.11 milligram per deciliter, and DEGFR decreases by 3.73 milliliter per minute. Those with less than 200, there is an insignificant change in serum creatinine or EGFR. Our own study shows that over-enthusiastic use of angiotensin-converting enzyme inhibitor, I do not know how many of here are clinicians, I suspect many are clinicians, over-enthusiastic use of angiotensin-converting enzyme inhibitor or angiotensin receptor blocker as renoprotective therapy, unfortunately, these drugs lead to end-stage renal disease. Chief of nephrology at the University of Florida, I go there, I'm a faculty there, showed me how the number coming down, EGFR dropping. And in fact, Fresenius, which is a big dialysis corporation, I get the memorandum, although I am not involved with them, but I get a memorandum because I admit my patient who required dialysis, that when the EGFR down to 30, you inform the patient that you have to get ready for dialysis. When it is 20 ml per minute, you tell the patient you have to get your fistula access for dialysis. But why? Why that happened? Because they are getting big time lisinopril. My patient don't get it. My patient don't drop to 30 ml. Take a look. Okay, here is a patient that classically, I don't know whether you can see very well or not, that hospital admission, the patient came in with a very high glucose, very low kidney function, serum creatinine of 5.8. I discontinued RB-shorten, diuretic, her kidney function improved, primary doctor put back her, and kidney function declined. Then finally I took over the patient care and she remained stable at a low kidney function but non-progressive. That's the word, progressive versus non-progressive. No studies in the past done, this paper will be published from India. The publisher is in India, current trend in endocrinology. No studies done in the past to determine if glycemic control with intensive insulin therapy reduces progression. That's the word, progression of impaired renal function, such as serum creatinine 1.5 to 2 into ESRD, serum creatinine greater than 5 milligram per deciliter. We did this study to show that there is a preventable. 46 patients studied, but we have a much larger patient, which I shall show you just a little bit. This patient treated with a combination of glargine insulin and regular insulin, but no S or ARB drug, excluded. No patient in my office get S or ARB drug. Now, I want you to focus on the colored, that there is a significant decrease of fasting glucose. There is both in the all patient and less than 200. We did not see any statistically significant decrease greater than 200, and serum creatinine also significantly less in this group. Now, take a look at the blood pressure. First visit versus last visit. All blood pressure control were normal. Some are significant statistically and some are not statistically significant. Remember, statistics can fool you sometimes, but if it does not, you get a p less than 0.5, does not mean you are wrong. It's not. Many statisticians worked with me. Even now, a big statistician, director of statistical center worked with me. A statistician told me, Dr. Mandal, when you go to the bedside, don't go by your allow your judgment based on P less than 0.5, allow your own clinical judgment. Because he knows he can be a patient, he wants a good care, not based on P less than 0.5. So all blood pressure were normal range at the last visit. And what they treated with? Beta blocker, calcium channel blocker, vasodilator or diuretic. No S or no ARB drug. Take a look at renal function. Not statistically different, but they are same, no change. And all these patients are in the range of stage 2 or stage 3, not stage 4 or stage 5 or end-stage renal disease. Progressive renal failure to ESRD, most likely due to oral anti-diabetic agent, as I showed you before. Take a look at insulin-treated and metformin-treated. Too much light on focusing on my slide. I hope you can see. 2-hour postprandial glucose, significantly lower in insulin-treated. Now, these are 64 patients. These are much different patients, but this is unpublished yet. But metformin, no difference in the 2-hour postprandial, not a significantly lower. Hemoglobin A1C, little higher insulin-treated, but the difference are not significant. And look at the serum creatinine. Insulin-treated, serum creatinine, no change, whereas significant increase in metformin-treated patient. And the duration is surprisingly different. This is a 700, next slide. Okay, 770 days, 17 days, follow-up insulin, metformin, 158 days. And you can see no change in serum creatinine in 717 days in insulin-treated, but significant increase of serum creatinine in 158 days. So what are the hindrances of effective management of diabetes or a prelude of complication? What are the hindrances? Commercialism, I keep talking to you, backed by powerful medical societies. And I must tell you something true to the heart. Omics Group has done wonderful, permitting many scientists, many doctors to present their work, to share their work with others who otherwise would not have been invited by powerful medical societies such as American Society of Nephrology, American Heart Association, American Diabetic Association. So Omics has done tremendous job permitting people, including myself, focusing on what is right compared to what is wrong, which are presented in those big medical societies. I know those people. I sat in the NIH committee with other people, what they do, drink and eat and look at the internet and never know what a patient look like even. So hemoglobin A1C recommended for diagnosis. It is not true. It does not help you making a diagnosis. No concern about postprandial hyperglycemia. Consensus panel by American College of Endocrinology. No definition of type 2 diabetes. Goal of therapy to reduce hemoglobin A1C. Emphasis on monotherapy, dual therapy. One oral did not work, okay, take a second one. Second one did not work, take a third one. Then when the patient develops foot ulcer, renal failure, then they tell, well, you have to take a insulin. Too late, already. Complication has developed. No emphasis on insulin therapy. No mention of postprandial hyperglycemia in the consensus panel. So what's the key summary? Elevated fasting glucose or hemoglobin A1C is often due to antihypertensive therapy. They come in 150, taking beta blocker, hydrochlorothiazide, and you are telling them type 2 diabetes? Wrong. Very wrong. Define diabetes by 2-hour postprandial glucose or glucose tolerance test. Random glucose greater than 200 signifies diabetes. Mono, dual, or triple therapy does not affect postprandial glucose. Combination of insulin therapy is permissive of glucose control, renal preservation, and cardiovascular protection. ACE, ARB are adversary in diabetes. So in conclusion, control of postprandial hyperglycemia is fundamental to preservation of renal function or renal protection in diabetes. Insulin is the cornerstone of therapy for control of postprandial hyperglycemia, and glycemic control may not be perfect, but renal function is preserved or other complication averted. None of my patients have foot ulcer, gangrene, or amputation. Their renal function is well preserved. Thank you very much. With my roses, I love roses and I cultivate roses. Thank you once again.
Thank you so much, Dr. Mandal. That was indeed a great presentation, a very, very informative presentation for all of us. Now I kindly request Dr. Shrinubabu Gadela to please felicitate Dr. Mandal with the certificate. Please give them a big round of applause. Thank you so much, Dr.